Check, check, check. interest of time, we want to go ahead and get started. We want to thank you for being here for our presentation today. We're all glad you're here. We're presenting the mass casualty incidents through a nursing lens, simulation, triage, and ethics. I'm Sarah Hemmen. This is Katie Morris and Amanda Turner. We are nursing faculty at SCC. So today's presentation will include a discussion of a mass casualty event or mass casualty incident and its impact on nursing practice. The material may reference some scenarios involving injury, death, or trauma, which can be emotionally difficult to hear or discuss. Please know that your psychological safety is important. If at any time this content becomes distressing to you, you're encouraged to step out, take a break, or access support and resources as needed. I know there are some resources of timely care on the table just outside this room for your needs. Our objectives today include explaining the triage process in an MCI, mass casualty incident, and how that differs from triaging patients during normal operations in the ED. And then we're going to discuss the ethical implications of limited resource allocation during an MCI, discuss how the mass casualty incident simulation prepares our nursing students to respond to MCI events in the field and in the hospital setting, and then we'll apply some triage principles to prioritize patient care during an MCI with limited available resources. But first we need to talk about what a mass casualty incident is, or an MCI. It's any event that produces more patients than a healthcare facility can manage. So that might come from a natural disaster, such as tornado, flood, earthquake, or hurricane. It might come from weapons of terror, such as bombs, mass shootings, chemical and biochemical warfare, nuclear warfare, or exposure. Or it could come from explosions or fires, or epidemics or pandemics, as unfortunately we have recently witnessed in recent years. During an MCI, resources are limited. That might be in the form of supplies, beds, hospital rooms, operating rooms, healthcare providers, ancillary staff, medications, equipment such as ventilators or IV pumps, blood products, and personal protective equipment, and even transportation. All those resources may be limited. There may even be a lack of clean water, plumbing, electricity, or oxygen at the facility or location, depending on the type of event. MCIs shift the standard of care, and what I mean by that is an MCI creates a situation where it is no longer business as usual during that MCI. There's a shift of priorities. In a non-disaster situation, the highest priority and allocation of resources is given to the most critically ill patients. For example, a client who is transported to the ED with a chest injury would receive all the life-saving care available, including cardioresuscitation, blood products, intubation, mechanical ventilation, surgery, medications, and a chest tube, even though there is a very small chance of survival for that patient. In a disaster situation, decisions are based on the likelihood of survival and the availability of resources. It may be determined that that same patient described earlier would not automatically receive life-saving treatment if it meant that fewer people involved in the MCI are given treatment. If other people are more likely to survive, then they will be the ones receiving the resources available. There's also a shift of leadership. Every facility must have a plan to implement a hospital incident command system, or HICS, and they identify various teams and team leads whom all report back to the HICS. This establishes a very important chain of command through which to operate the emergency response, coordinate all resources, and communicate. There may also be a federal, state, or local response of law enforcement involved, which is also unusual within the hospital setting. Nurses may find themselves in unexpected roles of leadership within their care areas. There's also a shift to the hospital's emergency operations plan. This plan is developed to manage all possible or actual or potential threats, and to provide protection of the community. Hospital accreditation requires that this plan is practiced at least twice a year. So the emergency operation plan includes several elements that I'll just kind of describe in brief here. There's an activation response. The EOP activation response of a healthcare facility defines where, how, and when the response is initiated. Communication is critical for all parties involved. This includes communication to and from the pre-hospital arena. A response is planned for organized patient care into and out of the facility, including transfers from within the hospital to other facilities. The site of the disaster can determine where the greater number of patients may self-refer. A coordinated security plan involving facility and community agencies is key to the control of an otherwise chaotic situation. Resources outside of the facility are identified, including local, state, and federal resources, and information about how to activate these resources. People management includes strategies to manage the patients, the public, the media, and personnel. Specific areas are assigned, and a designated person is delegated to manage each of these groups. A data management plan for every aspect of the disaster will save time at every step. A backup system for documenting, tracking, and staffing is developed if the facility utilizes an electronic health record. Deactivation of the response is as important as activation. Resources should not be unnecessarily exhausted. The person who decides when the facility resumes daily activities is clearly identified. Any possible residual effects of a disaster must be considered before this decision is made. Facilities often see increased volumes of patients 3 months or more after an incident. Post-incident response must include a critique and a debriefing for all parties involved immediately and again at a later date. Practice drills that include community participation allow for troubleshooting any issues before a real-life incident occurs. Food and water must be available for staff, families, and others who may be at the facility for an extended period of time. MCI planning also includes such issues as planning for mass fatalities and morgue readiness. A strong education plan for all personnel regarding each step of the plan allows for improved readiness and additional input for fine-tuning of the EOP. Nurses are involved in all aspects of an EOP, in their development, in their activation, and ongoing planning and preparedness. I remember very vividly and very clearly one of the things that I was involved in at the bedside in the NICU was a plan to evacuate all of our little tiny patients. And we had to come up with a plan, and we had to test out the new devices we were given, and they were actually sleighs with compartments, and we would put the babies that we were taking care of in the sleigh, strap them in, put their chart with them or whatever we could get with them, their medications, whatever information, and the nurse in charge of those babies would pull them to safety in an evacuation. Not something you want to have to do ever, but definitely something that needs to be practiced and planned for.
Can I piggyback on you, Sarah? Yeah. Hello. You guys, I've never held a microphone before. Just to piggyback on what Sarah was saying, for my perspective, working with adults with emergency preparedness, we also had the fancy little sleighs, but for much larger participants. And I vividly remember being like new baby charge nurse, and my manager was like, yeah, come, we're gonna do this training for evacuation. And I was like, okay, cool. And she was like, yeah, we're just gonna slide the patients down the stairs. And I'm like, you mean my 300-pound patient with BiPAP and, IVs and fluids? And it was just like, yeah, just do the best you can. And I was like, well, certainly. But I worked there for, 7 years or whatever, and you know how many times we practiced that? One time. So I think, my takeaway with this emergency operations plan is so important. It needs to be practiced. You guys know, anybody in here is you have to practice something to be good at it. I was just thinking about this. My kid has had like 14 fire drills in preschool so far this year. I feel like because I get an email every time. And hopefully he's catching on. But as nurses, it's so important for us to do those things. And at minimum, we at least need to know what our responsibility is. We might not know every single one of these bullet points, but hopefully you know what you need to do based on your floor, your patient population, all of that. Okay, sorry.
That's great. Okay, a mass casualty incident disrupts our typical nursing response and workflow, and the demands of patient safety, quality care, and ethical practice still need to be met. They are still our responsibility. It requires a shift in our nursing perspective, our critical thinking, and our ethical response. We're going to talk about a couple of different things during an MCI that affect nursing. So we have to shift from our routine practice. And so what I mean by this is that typically nurses care for a patient during an MCI, we need to focus on caring for a patient from the perspective that considers what's best for all people involved. And that's different from a standard shift when the nurses are caring for just one patient. We deliver care and advocate for more than just the essential care that's needed. In some situations, an evacuation from facility may be required, and then our nursing care and how we deliver it is even more challenging. Our shift of roles change as well. The role of a nurse in an MCI depends on the needs of the facility and the situation. Nurses can be tasked with any aspect of the emergency operations plan, either before, during, or even after the incident. This can include providing instruction and delegating care not only to patients, but to visitors and family members of the victims. Our scope changes as well. Nurses may be tasked with care that is outside of our area of expertise or even beyond our typical scope of practice. So, for example, if a critical care nurse is trained to intubate a patient, they may have to do so in an emergency situation and do that until a more qualified provider is available to assist. Our goals in triage. Nurses could be assigned as a triage officer. That means that nurses are responsible for assessing the wounded at a scene, while others are providing the essential care. Our triage focus very much shifts. Doing as much as possible to save a life shifts to the thought process of we're going to do the greatest good for the greatest number of people. So that goes back to what Sarah said in the very beginning. In an ER setting, we're going to provide all the resources to the sickest patient, but if somebody in the field requires multiple interventions, we may not be able to save them in the moment. Decisions are made based on a patient's likelihood of survival and the resources that we have available in the moment. Triaging actually occurs at multiple levels of care and should occur every time a patient is handed off. So that means that first responders will triage a patient, but that same patient is triaged again when they go into the ED because patient condition changes. I think everybody here is familiar with Maslow's hierarchy of needs. And so while we use Maslow's as nurses to help plan care for our patients, during a disaster, our thought process needs to shift. And we are really only focusing on the bottom two pieces, safety and physiological. When caring for patients in a disaster, our focus becomes our ABCs, airway, breathing, and circulation. And we are prioritizing what our patient needs based on how severely they're injured. Okay, this is the really fun part, the exciting part. So when we, oh, I can't. Yeah. I need to walk, I need to walk. Can you hear me? Can you hear me? Just yell louder. Okay. Oh, there we go. Okay. All right. Okay, so there are 4 colors that we use when we triage, and actually in a little bit you're going to have the opportunity to go over and practice triaging our paper dolls over there. So to classify a patient as red or immediate, that means that they have injuries that are life-threatening but likely survivable. So examples mean maybe they have a chest wound, or they have 2nd and 3rd degree burns on up to 40% of their body, or maybe they have a pneumothorax, okay? So when you're placing somebody in the red category, that means that you have the resources to do 1 or 2 life-saving interventions in order to stabilize the patient, okay? Somebody who's in the yellow category, it's also called delayed. And so that means that the patient has an injury that requires medical care, but they could wait a few hours, okay? So that might be a stable abdominal wound, a wound maybe that's bleeding, but they don't have any airway issues along with it. Fractures requiring open reduction. So again, these are patients that you see and you think to yourself, you could wait a few hours for treatment. There's nothing life-threatening happening here. Green or minimal, these are what we consider our walking wounded patients, okay? These are patients that could theoretically wait hours or days for treatment if they had to, okay? Examples might be minor fractures, minor burns, small lacerations, sprains, no severe bleeding. One of the ways that you can triage the green patients is when you walk into a mass casualty, first responders will often say, if you can walk, walk towards me. And so that tells you immediately that those people are likely in that green category because they're able to walk to you. And then the last category is black or expectant or dead. And so these are your patients that are unresponsive or almost close to being unresponsive. Maybe they have a very weak pulse, low respiratory rate, but these are patients that would require multiple life-saving interventions, lots of resources, which you just don't have in the field. So examples might be severe 3rd-degree burns on more than 50% of the body, shock, no blood pressure, no pulse, pupils are fixed, a severe spinal cord injury. Those are some examples that you might have to tag a patient black and move on. And that can be very difficult in a situation like this. Okay, we're going to talk about ethical dilemmas, some cultural considerations, and immediate and long-term trauma related to mass casualties. Triage and the allocation of limited resources required in an MCI can create ethical dilemmas for the providers. Nurses are still expected to apply all basic ethical concepts, including justice, beneficence, non-malfeasance, autonomy, fidelity, veracity, and accountability, all to the best of our abilities. So for instance, not providing life-saving care to a person with the most severe injuries is in direct conflict with the ethical principle of beneficence. Additional types of ethical dilemmas during an MCI may include those of confidentiality, consent, duty, rationing care, and resuscitation. Depending on the size of the community, there is a good chance that a nurse will know or be related to some of the victims of the MCI. That can add an entirely different layer and ethical dilemma for the nurses. Although MCIs typically affect members of diverse cultural, religious, and ethnic backgrounds, some MCIs can be a result of a certain group being targeted in the destruction. This can bring about additional psychological trauma for all of us caring for these patients. In addition, MCIs that target specific groups can further exacerbate our healthcare disparities that may already exist. Can also make it even more difficult to achieve better health outcomes among its members. The psychological trauma from an MCI can have immediate and long-term effects on a community and among the nurses involved. Possible responses can include anxiety, depression, post-traumatic stress disorder, and even substance abuse. Nurses may experience moral conflict, moral distress, moral outrage, or even moral injury as a result of the distressing psychological, behavioral, social, and sometimes spiritual aftermath of exposure to events that contradict deeply held moral beliefs and expectations. Healthcare workers may not have time or the resources to process our moral dissonance, which can result in nurse burnout.
Okay, so nursing education and MCI. So I think we all like to think that anybody who goes into nursing is a good person, and I think that that's probably true. But from an education perspective, we still kind of have to have a framework for ethics and how those are included and taught and kind of brought about, because I'm sure, as you guys all know, just as humans and students, and especially nursing students, it's scary when you're faced with something that you don't know how to handle or that you've never thought about, right? So the American Nurses Association Code of Ethics for Nurses kind of puts in writing what the general consensus is as far as ethical expectations for nurses. So it's things like, respect for the patient, regardless of culture, situation, beliefs, all of those things, that our duty as nurses is to our patients, right? So it's kind of our compass for that. So we, of course, in various lectures, I think your very first lecture as a nursing student, we introduce ethical principles, and those are brought back around in various nursing courses, in, clinical assignments, simulation discussions, all of those things. And then how many of you, I know we've got lots of nursing students here, but have had to do some reflection in your clinical paperwork, your debrief. I heard some debriefing reflection questions being thrown back at poor Katie and Sarah. So I feel like, I hope, at least, especially for the nursing students that are here in the room, or for anybody who maybe wants to join nursing school, that you don't feel like ethics is something that is a foreign topic that hasn't been discussed. How many of you in clinical thus far, if you're a nursing student here, have been put in a situation that you felt like, by golly gee, I'm not really sure what to do here, or if I were on my own, I don't know what I would do, right? So you want to think about those and reflect on those situations, so that when you are on your own, you know what your resources are, you know what help you have, you know what the ANA kind of expects out of you, and hopefully we're guiding you through that process. So as far as MCI simulation at SCC, so this is a really cool opportunity that, again, those of you that are a nursing student or prospective nursing students will hopefully get to participate in. And it's been developed over the years to give you some really great opportunities. Developing new skills. So I think a lot of times, when nursing students hear skills, you think, oh, I'm going to put in a Foley, or I'm going to put in an IV, or whatever. But there are so many skills in nursing that are not those, skills that are, a procedure on a patient that are so important. So things that we really focus on during our MCI drill are things like teamwork, leadership, right? Advocating for your patient, making those difficult ethical decisions that maybe you observed in the clinical setting, but this is really giving you an opportunity to do that in a safe space during a simulation. And for those of you that maybe don't know what simulation is, if you're not familiar with nursing education, simulation is an opportunity for nursing students to come in to our campus. We have what we call our virtual hospital that's kind of set up just like a regular hospital, and our nursing students take care of mannequins, or sometimes we have live patients that come in, so it gives our students an opportunity to act as a nurse without harming anyone. So anyway, again, with the new roles, we've got leadership roles. Maybe, you've been a nursing student or you've been a tech in a hospital, so you kind of understand how that goes, but you've never really had a chance to be a charge nurse or a nursing supervisor or, somebody to do the triage. So lots of opportunities for new skills and roles with our MCI simulation. As Katie was mentioning, there's an opportunity during the simulation to shift that mindset from thinking about that one really sick patient to looking at, okay, I'm going to have to make some difficult decisions and possibly, leave somebody behind because I know that I can save, 5 people if I focus my attention on this, as opposed to having, 5 or 6 nurses focusing on one singular patient. And that's a really, really hard thing to do because, again, as many of you know, as a nursing student, you want to do all the things. You want to do all the things. That's why we came into this. We want to help people. We want to help everybody. So it's really, really hard when you're in a position that you can't easily do that. So again, that is something that's explored for sure during that simulation. As far as moral courage required for ethical dilemmas, again, maybe those of you that are in clinical or work in healthcare currently or out in life, you've seen ethical dilemmas that have really challenged your beliefs and what you feel is right. And at SCC in our nursing program, we want to give you those opportunities to say, hey, really stand up for, even though it's not a real patient, we want to still give you those opportunities because practice on that is really, really important, just like the emergency operations plan. All right, so what does our simulation look like? So for those of you that are currently students, you'll get to experience this soon enough. This simulation is going to be for our graduating students. If you have never been to SCC, our CHL campus where our nursing program is, we have a really big, beautiful library. And as I mentioned, we have the virtual hospital that is essentially set up as a hospital setting. So for setup, essentially what we do is we destroy the library. And we knock over tables and trash and all of the things to be our simulated area of some sort of mass casualty event or disaster or whatever. We have our virtual hospital set up as the ED. And then we have a lot of amazing volunteers that come in to be patients. Okay, which definitely adds an element of realism to the whole simulation. And they're pretty great amateur actors. Lots of screaming, crying happening. That really makes it feel real for the students. So there's multiple evolutions of this whole simulation. We have students that are split up into groups. So everybody gets an opportunity to triage in the library at the location of the mass casualty event, and then everybody gets an opportunity to act as an ED nurse that's receiving all of those patients that have been triaged at the site of wherever the mass casualty incident was. We do have a nursing lab that we turn into the PACU because we know, as Katie and Sarah mentioned, sometimes when that emergency operations plan is activated, certain areas that maybe are used for one thing are all of a sudden changed. Maybe the PACU is used for incoming patients. Maybe we've got, a waiting area that's all of a sudden used for, treatment. Maybe we have to be able to be flexible and shift what we're doing in that moment. So that's what the nursing lab is. That's the MCI. It's a really super fun, as fun as an MCI can be, but it's a wonderful learning opportunity, and it's really always fun for, I think, us as educators to see how into it the students get and how much is learned from that experience. So it's great. All right. What questions do you have? What are your thoughts? Do you have any questions about MCI? Yes, ma'am. So I'll be totally honest with you. I don't feel like I've ever been, as a nurse, at the bedside in a mass casualty incident. I've been very fortunate that where I worked,
So for me, the closest, I guess, parallel to that would be, just having some maybe unstable patients and not enough staff. And that's something that you experience every day. And I do think that that's really tough for nurses because you're always having to reorganize your priorities and you're doing your best, and maybe that's not what's best for your patient. And I wish I had the answer for that. We might save bedside nursing if I had the answer to that one. I think it's a lot of the reflection, kind of thinking about, reflection and self-care and all those things that we try to tell you that you maybe roll your eyes. That doesn't really answer your question. I don't know. You guys have anything?
So I'm the same as Amanda. I've been very blessed to not have to take on that role in a mass casualty. But actually, Sarah's cousin, she spoke to one of my trauma classes years ago. She was a nurse during the Joplin tornado, and she worked the night the tornado hit. And so this kind of answers your question, Kelsey. Something that she said that was very powerful was that you're taught all of these things in school, and you think, I know exactly what I'm going to do. And then that moment happens, and you realize, I don't know what to do. I need to pause. I need to think. And she talks about how in that moment she took that pause and thought about what her next move was going to be. So I think, again, that kind of goes back to what Amanda was saying. In that moment, you have to reflect and refocus. So I wish we had better advice, but I'm also grateful that we've not had to be in that situation.
And I just want to add more merit to the question, because since many of us probably will never experience something like that, the thing to do would be to talk to people who have and find out, how this might affect you in that moment. My closest experience would be working during the pandemic, and not necessarily an MCI that lasted a matter of hours. It was a matter of months, right? So that would be my closest experience, and even still very different from an MCI that we're talking about today that requires triage, but still very valuable. Yeah. Absolutely.
For those who don't know me in the room, I'm Jen Lutton. I'm the area overall nurse, but I've been a nurse for 30 years, and I was a nurse during 9/11. And so while we were not affected here in St. Louis during the 9/11 tragedy and haven't had any terrorist attacks on our area, as soon as the planes hit and we realized what was happening, we activated our plans. So at that time, I was a director of labor and delivery. So we weren't necessarily going to be the individuals who were taking in the patients, but we did send home in the elective induction. That was safely sent home. We handled all of our C-sections. We emptied out our GYN beds so we could take the influx of patients that might be coming from other areas to open up the ICUs and the step downs and things along those lines. And as the director, I would lead these calls to meetings to evaluate our resources. We called in staff. We started to activate a plan just in case, because while we had not been affected, there were enough areas in our vicinity that could have been targeted. And so and I was a smallish community hospital at that time. I was at St. Joe Kirkwood, which doesn't exist, but is now St. Clair. So we were ready to essentially absorb so that our bigger trauma hospitals could take on what they needed to take on. So that's about the closest in my 30-year career that I've been to dealing with a true disaster in our area.
Do you guys have any other questions? Patty?
So I know that there's like, whenever you get hired, there's like a book you have to read and like rules and what you do. But you said that especially training for this stuff, you don't have to use forms. Am I saying that right? So if that happens, do you ever see induction where they're like, have someone at the table show you this sled, or are very complicated?
That's a great question, and my answer would be your first go-to would be your charge nurse, or maybe that seasoned nurse on the unit that you know that you're comfortable with. Yeah, it's a great question. Tyson, did you have your hand up?
Yeah, I don't know if it would be more I was a little surprised that airway was one of the wasn't how it was in triage. Because it's like, it's airway takes a lot of management. And so I know on the battlefield you don't manage airway.
Correct.
That's
Yep.
what it is. So those are expected. All right. Now maybe I'll go
practice on a mannequin when we demonstrate those skills. I would not be intubating unless it was these circumstances. I have been taught, I have been trained, but I wouldn't do it if there's somebody more qualified to do it. It is, as long as you're operating within your scope and within your training and credentials, no. Yeah. Well, just to address that, it's not exactly expanding your scope. You're still within your scope, but you're doing more than what you would typically do on a day-to-day basis. Okay.
One of the weird things in the state of Missouri is that the state of Missouri's Board of Nursing looks at our scope of practice individually in many aspects. If you've read at all in our Nurse Practice Act, it's not terribly helpful or terribly guiding, right? And if you stood, I see 5 of us up in the room right now that are already nurses. If you stood the 5 of us up, according to the Missouri State Board of Nursing, we would all actually have slightly different scopes of practices based on our experience, our training, and our demonstrated competence. I can guarantee you, Sarah and I are the only ones in the room right now who would even attempt a neonatal intubation. The other 3 would be like, yeah, heck no, not gonna happen, right? But Sarah and I, every year for many, many years, have gone through that repetitive training. Have I had to do it? Almost once, and it wasn't even an emergency as far as mass casualty, but we had exhausted the limits of the individuals at a small community hospital who knew how to intubate. And thank God, when I had the kid in position, I had the laryngoscope in my hand, I was about ready to insert the blade, and an anesthesiologist came up to the OR and felt comfortable with neonatal intubation. But that's how close I had gotten, and it wasn't an emergency event as far as mass casualty, but at a community hospital, I had no other, and it was also 25 years old, we didn't have as good of alternate airways other than intubation, right? So the State Board of Nursing takes into consideration your situation and scenario you are in when you're doing that, your prior experience, the other individuals around you, and other education that you might have received outside of nursing school. So scope of practice, while we want it to be really clearly defined,
Just isn't.
which is a great thing when you need it to be, and a frustrating thing when you're trying to find the line. It does, right? And good Samaritan laws help us. I mean, like, there's a lot of things that do protect us as nurses, as long as we're not, putting on our superhero cape when it's just a, scope of rule, right? Yeah. It's got to be applicable. Sorry, I really tried to.
It's okay.
We appreciate you very much.
Otherwise the NCI is activation. We know that because we're all going to cases. We've got well-known specialties in our system.
Okay. We love your questions. Selfishly, we are going to move on to our activities. We can get to that, and then you might have even more questions that are also fantastic. So, we want to give you guys the opportunity to practice your triaging skills. So we are, if you'll notice over there on this side of the room here, we have some paper dolls out that are going to have some very brief patient information on them in addition to a number. We are going to have you guys split up into groups of 3 or 4. And then what we'd like you to do is practice triaging the dolls that are out there. So we are going to pass out a paper, like a sheet for you guys to fill out to practice triaging the patients. And then after you've completed triaging the patients and marking on your sheet whether you think they're red, yellow, or whatever, we'll come back together and look at the answer key together. We're going to also put out a piece of paper on the table that's got a QR code with the answers so you can follow along. Just don't look at that till we're all done.
But you're going to need this information to be able to do some triage. So Katie's going to explain some RPMs.
Okay.
Oh, it's for everybody.
Oh, yeah, no, please participate.
Please join us.
Yes. Well, they're going to help you.
Yeah.
It's going to be great. Yeah, they haven't had it either. Okay, so you guys are going to see some abbreviations on the paper dolls, and I want to explain what you're looking at. So each paper doll will have RPMs, and also some of them will have capillary refill. So just a reminder, the normal respiratory rate is 12 to 20. P stands for pulse. Remember, normal is 60 to 100. M stands for mental status, so determining if they're alert and oriented. So it's either they're completely alert and oriented, or it's alert and oriented times 0. That's what you'll see on the paper dolls. And then as a reminder about capillary refill, which is going to help us determine perfusion, less than 3 is normal, greater than 3 in our brains we're thinking poor perfusion, okay? So please get yourselves in groups of 3 or 4. Please help those in the room that are not nursing students, and your faculty will be down to answer any questions while you're going through the activity.
Oh, you want the, here, can I put the chart back up? Is that okay? Or do you want it?
I think they need that more than anything.
She was asking for the red, yellow. Okay. Oh, is this on? Okay, you guys. Hello. So we very much appreciate you doing this and really thinking about it and all the discussion. We do have a couple debrief questions that we want to run through with you. So if you don't mind kind of swinging back over here, that'd be great.
It's okay if you didn't get through all of it. I don't think this is
Yeah.
Should I advance?
Yeah. Okay. All righty. So we know we don't have much time, but we want to at least kind of talk about a couple of things as far as the activity goes. So, how do you feel this activity impacted your understanding of triage? Oh,
There will be big simulation.
yeah. Remember that big thing we were talking about? It will come back around. Okay, so you at least feel like maybe you have a slightly better idea on triaging and the difference between maybe triaging on a normal day versus an MCI. All right, check. All right, which actions or decisions during the activity gave you the most confidence? Hmm.
Oh, so knowing that you had those 4
Oh.
Okay.
Just a multiple choice situation. Okay.
Which is nice when you come across the patients where you know you have to potentially leave them behind, and you can kind of. I like your thinking. You're like, it's inside the box. I'm reading the box. Yeah, I like that.
Yeah.
Yeah, good.
Yeah.
Tyson had it.
Yeah, I was gonna say, Katie came over at one point and sort of talked one through with us. Well, we just sort of told her everything we were thinking about it, and she kind of confirmed that. But so getting a more experienced, staff, faculty, nurse, whatever, to kind of game it with you and walk through it. So I think I felt more confident with it.
Yeah.
So I know that in these type of scenarios, like the people sometimes they are out of themselves, like they are alterated, they are stressed, they don't follow commands.
Yeah.
So how can we deal with it while we are still trying to give them support or like medical assistance?
Great question.
So you bring up a great question, and when you have patients that you feel like maybe can't be left alone for some of those reasons, you can find another person, maybe even somebody who has been trained in first aid or somebody who's not injured, that you can say, can you stay with this? Can you sit next to this person? Because you're right, sometimes all patients need during a scary situation is someone to just sit there and be with them. And as you know, we can't do that during a mass casualty, so assigning that role to somebody else would be very helpful.
So I guess with the patient that you came up to us with, their only, at least apparent issue is their sugar is 30. Like, is something that you think you could quickly, like glucagon, sugar, get them something? Like, had you just give them that? I hope that works. Move on.
So you've opened up a great question that there's kind of a lot to explain, but in a very what you would see in a real disaster would be triage areas set up. So when patients are taken to either the green area or the yellow area or the red area where those life-saving interventions may happen. And then while I don't want to say, yeah, you give it and then you leave, those patients who are critical, they have that life-saving intervention, they're transferred to the emergency room, then they're reassessed and re-triaged in the ER. And so if you've given glucagon or whatever, in theory, that patient probably went from a red to a yellow or even better. Does that help a little bit? Okay.
All right. We realized that this was just an introductory activity and all of the things, and all very new. But is there anything maybe moving forward, whether it's the SCC MCI or potentially even a real one that you guys would do differently? Yeah.
I think the thing that I didn't realize as much with this, like once we started, I got it, but it's like when we're in like our sim or we're doing a deliberate practice, we sit there and think through a lot more, and we're like, well, if they have this, this could cause this. But with this, it's very like cut and dry, like
You're moving
it's there.
fast.
Yeah, you have to like just take what's right there in front of you instead
Yeah.
of like, oh well, then this may, you know what I mean? It's
Yeah.
like you just have to like in the moment.
Yeah.
In order to help with the most people, you have to be on your feet and you just have to like say, okay, here you go, and move on. Because it's like
Be decisive.
you can't.
Yeah.
And oftentimes there's another wave of triage that happens after the initial triage. So
Somebody
even,
else is gonna help.
yeah.
What did you guys find most challenging?
So since you don't have like those orders in that time, you have to know certain things that
Yeah.
you can't do and you can do with like what the patient has already, or what's gonna make it worse, what's gonna make it better. You don't have orders. Like you are on your own, and if you don't know, you need to find somebody to ask quickly.
Yeah.
It's a great point.
Yeah. Did you guys feel like, oh, I'm so sorry. Go ahead.
I was just saying the only thing that made this difficult, which we can't do because of papers, but it's like knowing the lacerations versus wounds. Sure.
Yeah.
That would be, we can see that obviously.
Yeah.
Right.
Yep.
Did you guys feel like as you were going through that you encountered any ethical dilemmas or moral dilemmas?
We ran into another group triaging, which like, we need clear delineation of roles here. You say,
I think because it was paper, it was a lot easier to
Right.
realize like this person would be in the black category.
Yeah.
But being there in the situation, I think it would be a lot harder.
To leave somebody behind or, yeah, for sure.
That's what I was gonna say, like piggybacking off of her, because on the paper it's like cut and dry this, but I
Right.
feel like if you're like, well, we could do this and save them, but it's like, is that appropriate at this point?
Right.
Well, and live patients talking to you, looking at you, pleading, having emotions. I mean, paper dolls, like you guys are saying, are easier because we're missing that human component, you know?
But I think kind of understanding those categories and what they are and what we're looking for makes those decisions easier because you know you're doing the greatest good for the great amount of people and you really have to kind of hang on to that when you have to make those really hard decisions. Yeah. Okay. Okay. Thank you guys so much for your participation. We appreciate it. We're going to put up the answer key here. If you want to take a look and kind of compare what you all put down.
I handed out some paper copies too, but if you guys have any questions, we will hang around for a few minutes. Like Amanda said, thank you for coming. Thank you for participating.
Thank you.
Thank you for being here. And we'll see most of you back in sim in a little bit.